Hi, and welcome to Radonc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I am currently a PGY 5 resident at the University of Pittsburgh, and today we will be discussing craniospinal irradiation, also known as CSI, specifically focusing on the physics behind the planning for CSI. Craniospinal irradiation is most commonly utilized for pediatric patients. There are a few different pediatric CNS tumors, such as medulloblastoma, non-germinomatous germ cell tumors, atypical teratoid rhabdoid tumors, and ependymoma if there are metastatic deposits in the spine or in the CSF, where we really think about using CSI. In adult patients, CSI is less commonly used. Indications have sort of dwindled in the fields of leukemia and lymphoma. But we do sometimes utilize CSI for the management of metastatic leptomeningeal disease. For example, breast cancer patients sometimes present with leptomeningeal spread, and CSI seems to show some benefit for those patients. In this particular talk, I'd really like to focus on just the physics behind planning for CSI, discussing the technique, how we simulate our patients, how we design our fields. CSI involves using multiple fields, including a brain and 1 to 2 spinal fields, if not more. And so we'll talk a lot about how we match those to try and minimize the overlap between those fields. And then in the end, we'll discuss kind of protons versus photons, followed by some of the toxicity that's caused by CSI. Now, the talk that is kind of attached to this lecture here is really the second half of my Pediatric CNS Overview talk. So this talk was really geared towards CSI for pediatric patients, but keep in mind that it can be used for adults as well. I just thought it might be beneficial to kind of also separate it as its own video for folks that are purely interested in hearing about CSI. So with that little intro, let's get started. When we treat with CSI, we're trying to treat the entire brain and the entire thecal sac as defined by the MRI. So that usually takes us to the bottom of S1, S2. So brain plus the entire thecal sac. That is the entire craniospinal axis. So anywhere where there is CSF, we want to treat that entire area, right? Whole brain, entire thecal sac all the way down, usually to the bottom of S1, S2, as defined on the MRI. So that is our target, and that's what we're trying to cover. Now, how are we actually going to cover that? So typically, there are multiple fields that we need. We need a whole brain field, which is usually done with 2 lateral beams, and then we need a spine field, which is usually done with PA fields, so posterior anterior field, a single PA field, and depending on how tall the patient is, we might need at least 2 or maybe more fields to cover the entire spine. Typically for pediatric patients, it's going to be a whole brain field with 2 laterals and then 2 PA fields. So one to cover the top half of the spine and another PA field to cover the bottom half of the spine. So these are our fields, okay? And each field is going to have a different isocenter. So typically we have 2 to 3 isocenters. So 1 isocenter for the whole brain field, and then 1 or more additional isocenters for depending on how many PA fields we need to cover their entire thecal sac. So when we simulate these patients, we really want to be conscientious of how our fields are going to be entering the patient and what we can do to kind of make that flow as smoothly as possible. So when we simulate our patients, we want to have them supine with their shoulders down and their neck extended and try to minimize any curvature of their spine. So why do we do all of that? Well, we keep their shoulders down so that when our lateral beams come in, our opposed laterals for their whole brain field, those fields aren't going through the patient's shoulders. So we try to keep the shoulders down as much as possible. We keep their neck extended because our PA field is going to have some divergence, and we want to avoid the divergence of that PA field from going through the patient's oral cavity. So that's why we try to keep the neck extended. And then we want to keep the spine as straight as possible because we want our PA field to be as narrow as possible and not have it go through a lot of unnecessary tissue, right? We don't want to irradiate unnecessary bowel. So we want to try and keep their hips kind of aligned with their shoulders and try to minimize curvature of the spine kind of a sideways curvature. And we also want to try to minimize like lordosis and kyphosis and things like that. So to try and achieve all of that, we ask them to be supine, shoulders down, neck extended. We use a 5-point mask to secure their head and shoulders, and then a large vac lock for their body and check for straightness of the spine. And sometimes a knee sponge can help to reduce the lordosis of the patient, or that lumbar curvature. And we try to keep these patients in this position, for the reasons that I mentioned. And keep in mind that oftentimes when we're treating pediatric patients, if they're very young, they might need general anesthesia to be able to lie still for the length of treatment. So that's simulation. Then when we're contouring, as we said, our target is the entire brain, and we want to ensure our field is covering kind of the cribriform plate, the crista galli. We want to cover that entire, that area, as well as the base of skull. And then the entire thecal sac as identified by the MRI. And then I have a picture on the right-hand side of what the spine contour should look like. And we're not just including the spinal canal, but we're also extending along the nerve roots laterally to ensure that we're covering the nerve roots as well. So anywhere that there is CSF surrounding the craniospinal axis, we want to include all of that in our target. And then finally, as we said, when we're thinking about our fields, we're trying to have 2 lateral beams, so opposed laterals, to cover our whole brain field. And then we're having 1 or more PA fields to cover the entire spine. Now, this whole thing gets very complicated because of the flashlight effect, right? And that is if you shine a flashlight and you're standing 5 feet from a wall, you're going to have a certain radius of the light on the wall. If you shine a flashlight and you're standing 10 feet away from the wall, suddenly your radius that you see on the wall is going to increase, right? And that effect is known as divergence, where the beam's diameter, and a radiation beam is essentially a giant flashlight. The radiation beam's diameter increases with the distance from the source. So as a beam is going through the body, you have to imagine its divergence and the fact that because of scatter and things like that, it's also going to be, treating a wider radius as you continue to go through the body. So that is divergence. When we stack multiple fields on top of each other, we actually get hotspots that are created in the areas where the fields overlap, and we get cold spots located just behind that area of overlap. So that's what I've tried to show with the red and blue triangles here on this slide. We get hot spots where the fields overlap, cold spots just behind. So there are a couple of things that we can do during CSI to try and minimize that overlap and try to mitigate that hot spot. When we're thinking about the overlap of the divergence between the whole brain fields and the spinal fields, we have an advantage because they are on different axes, right? The whole brain fields are opposed laterals, and then the spinal field is actually coming in perpendicular to that. So when we're matching our brain and spine fields, we can actually rotate the patient in such a way that minimizes their divergence into one another. And we'll talk about how we can actually match those fields and how we rotate the patient and the collimator to try and kind of minimize the fields diverging into one another. We have the advantage of being able to do that for the whole brain and spine fields because they are on different axes. If we did that while we were treating the spine, though, we would end up probably missing some area, or it wouldn't work out to kind of rotate the patient in such a way to match the divergence. So in the spine, we're kind of faced with this flashlight effect where when we stack the flashlights, we get these hot and cold spots. So what we can actually do is minimize the area of those hot spots by what we call feathering the junction. That means every few treatments, we actually move the match line of these beams by about 5 to 10 millimeters so that we actually spread out the hot and the cold spots. It kind of helps to create a more homogeneous field, right? So instead of having the same exact position in which those flashlights are stacked for the entirety of treatment, we have them stacked at a certain measurement for the first 5 treatments. And then after 1 week, we shift them by about 5 millimeters so that their positions are now different. And then we shift them again by 5 millimeters after another 5 treatments so that their positions are different. And you can imagine that then kind of helps to spread out where the hot spot is created, where the cold spot is created, and it helps to create a more homogeneous treatment. So this is a visual representation of what I mean by feathering the junction. Every few treatments, we shift the match line of the fields, and what that does is it shifts where the hot and cold spots are inside of the patient. And over time, rather than treating in the exact same positions for the entire treatment course and having that hot and cold spot be exactly where it was to start with, what we do is we shift where the hot and cold spot is every few treatments, and that ends up creating a more homogeneous dose distribution. So hopefully that gives a good broad understanding of what we're trying to achieve with CSI. Let's get into some more details and some of the specifics around how we design the fields, how we match the different fields. So starting with designing our isocenters and where these fields are going to be located. Typically, in an average height child, we're dealing with about 3 total fields, right? The first field for the whole brain, then the upper spine, and then the lower spine. So it helps to plan the upper spinal field first, that single PA field. And what we want to try to do is keep the upper border of the spine as low as possible. So ideally around C4, C5 or C5, C6, and depending on the child's height, it'll probably go down to about L1, L2. When we design this field, again, upper border as low as possible, and we want to avoid exit of that divergent beam through the oral cavity. Hence, we simulate the patient with the neck extended. Then we think about our whole brain fields, and we're thinking about giving 2 opposed laterals, right? So when we're designing our whole brain fields, we want to ensure that we're covering the entire brain. So make sure that field inferiorly covers the cribriform plate, the crista galli, as well as the base of skull. And we want to avoid entering through the patient's shoulders. It's okay for us to have about a 0.5 cm gap between the brain and spine fields. And then finally, on the opposite side of the patient, we want to plan that lower spine field and any additional PA fields if we need more than 2 to cover the spine. But typically, in an average sized child, probably 2 spinal fields will be sufficient. What we want to do is, as we talked about with that flashlight effect, wherever those 2 divergent fields match, wherever that match point is, just anterior to that, we're going to have a hot spot, right? And posterior to that is going to be a cold spot. So if you think about it logically, where would you rather have your hot spot? Right in the middle of the spinal cord or just anterior to the spinal cord? Hopefully you're thinking just anterior to the spinal cord, because we don't want to have excess hot spot right in the middle of the cord, right? We're okay with having it just anterior to the cord inside of the vertebral body. So when we match these spinal fields, just like what is shown in the diagram here, we want to have the match point of those divergences be just anterior to the spinal cord so that we get a cold spot in the cord and we get a hot spot in the vertebral body. So we've thought about our fields, we've thought about where we're going to place the isocenter. Now, the most complicated part of all of this is probably matching the brain and the spine fields. Because remember, the brain we're treating with opposed laterals, and that's going to have an inferior divergence into what we're treating with the spinal field. And then the spine we're treating with a PA field, and that's going to have kind of this upward divergence into the whole brain field. So we want to try to minimize the overlap between our brain opposed laterals and our spine PA field. So how do we do that? We can do 2 things. So when we're treating our whole brain field, rather than just slapping on 2 squares on either side of the patient, we can actually rotate the collimator so that the bottom edge of our brain field kind of parallels the upward divergence that's created from the PA field. And a visual representation of that is shown on the left-hand side of this table. See how we can see the PA field for the spine and its upward divergence, and then the collimator is rotated at a specific angle, so the bottom edge of our square kind of parallels that upward divergence that's created by the spine field. So there is a formula for calculating the degree of this collimator rotation, and it's given in that box below, but generally the angle is about 12 degrees. That takes care of the issue of the spinal field going into our whole brain field, right? That's sort of one plane in which we're seeing the divergence. But the other plane where we're seeing the divergence is from the whole brain field itself, there's going to be some divergence, right? Because even though we are angling the collimator to match the divergence of the spinal field, that whole brain field itself is going to have, it's like shining a flashlight into this page. So there's going to be some divergence into the spinal field. So the other thing that we can do is when we are treating for our spinal field, we can actually kick the couch towards the head of the gantry so that the top edge of our spinal field matches the downward divergence of our opposed laterals. So what I'm talking about there is represented on the right-hand side of these images, where we're actually rotating the couch so that the top edge of our spinal field is parallel to the downward divergence that we get from our whole brain field. And there is another formula to calculate the couch angle, the degree of the couch kick that we need. And that is also given in the formula underneath the diagram, but that angle ends up being about 8 degrees. So this is very difficult to wrap your mind around, and you probably need to draw it out yourself or stare at this slide for a very long time, or just hear the last 3 minutes of what I've said again and again and again. But once you wrap your mind around what is happening, and it takes me a long time to grasp these sort of three-dimensional concepts in my mind sometimes, but once you wrap your mind around what is happening, there are two things that need to happen when we match our brain and spine fields. Number one, we need to rotate the collimator for our brain field so that it matches the upward divergence from our PA spine field. And then number two, when we're treating the spine field, we actually need to kick the couch towards the head of the gantry so that the top edge of our spine field matches the downward divergence of our brain field. And there are formulas for that. So the formula is basically the angle equals the arctan of half of something divided by either the SSD or the SAD. So it's different depending on what you're calculating. So when you're calculating the collimator rotation for the brain field, it's half the spine field length divided by SSD. And then when you're calculating the couch kick for the spine field, it's arctan of half the brain field length divided by the SAD. Now, these formulas are very complicated, and I don't have a good explanation for why they are the way they are. This is just something that I memorized for the physics board exam, and I recommend you memorize it as well. But hopefully we at least conceptually understand what is happening and why, and then we can kind of just commit these formulas to memory and get those questions right on the board exam. The final little thing I'll mention here is, there's a big deal around the fact that the couch kick is toward the head of the gantry for pediatric patients when we're doing CSI. The reason, it can get confusing is because in breast planning, there's also a couch kick sometimes when we're using kind of a dual isocenter planning technique. And a couch kick needs to happen to deal with the divergence of the tangent fields and the divergence of our supraclavicular fields. And that's a whole conversation for a different lecture. But the bottom line is in breast planning, we deal with a similar issue when we're trying to match two fields when we're doing regional nodal irradiation. And there needs to be a couch kick that happens. The difference is in breast cancer patients, that couch kick is done away from the head of the gantry. So the patient's feet are moved away from the head of the gantry. Whereas in CSI, the couch kick is toward the head of the gantry. And the mnemonic to kind of remember that difference is think of hugging a child close to you and pushing an adult away from you. So when children are sweet, they're very cute, you pull them close to you in a hug. So the couch kick is toward the head of the gantry. Adults, not so nice, we push them away, so the couch kick is away from the head of the gantry. And that's the simple mnemonic. But just remember for CSI, when we do that couch kick, it's toward the head of the gantry. Okay, So we've hopefully understood now the mathematical wizardry that goes behind matching those brain and spine fields. And then there's one last piece of the puzzle, which is matching our multiple spine fields. And we've already kind of talked about this, but now let's put the math behind what we've talked about. So as we said, we try to match the spine fields anterior to the spinal cord. It doesn't have to be anterior to the vertebral body, just right anterior to the spinal cord so that we avoid the hot spot in the cord, and whatever hot spot we get goes in the bone, which is important but less important than the cord itself. Whenever we match these fields, right, the divergence is matching within the patient, right, at a depth within the patient, whatever depth is just anterior to the spinal cord. What the therapists are going to see on the patient's skin, and when they're making sure that they're treating the appropriate field, they are going to see a separation between the two fields, and that's kind of shown in this diagram here. So from the therapist's perspective, they have the beam and they have a certain field size, and we understand that whatever field size is drawn on the patient's back, inside of the patient, that field is going to grow because of divergence. So the fields are matching at a particular depth, but what we see on the patient's surface is a separation between what we're treating on their spine. So what the therapist can do is they can actually place a marker on the skin and check the skin gap. And another problem that you might have to solve for physics board exam is calculating what that skin separation should be. And they will tell you that you're, trying to match fields at a particular depth. They'll tell you what the SSD is, and they'll also tell you what the length of your field size is on the patient's surface. And they'll ask you, well, what should the patient's separation be between the two fields? And one thing that you can do is just use a principle of similar triangles to identify what the separation is. And, one triangle is the SSD ratio to the length of the field itself. The other triangle is the depth of the field and then the separation that we see between the fields on the patient's surface. So you can use similar triangles, or you can memorize the formula that I have in that blue box. But either way, that's another formula / mathematical concept you should be familiar with for board exams. And that is basically calculating the patient's separation. And, one thing, when I was talking about how we simulate the patient, I have been taught that it's easier to simulate the patient supine, but I should also add that, it's possible to simulate the patient prone, and it's probably easier to kind of see these skin markings and exactly where the fields are on the patient if we simulate them prone. But that is probably an institutional preference and a physician preference in terms of how we simulate them. We can do CSI supine or prone, but it's probably easier to see these marks on the patient's back if we're simulating them prone. So we calculate that skin gap between the two different fields using the principle of similar triangles. And then going back to that concept of feathering the junction, as we talked about and explained earlier, we're going to have a hot spot in the vertebral body and then a cold spot in the spine that's just posterior to that match point of the two fields. So we typically try to move the match line every 5 treatments or so, so typically once a week, and we move it by about 0.5 centimeter to 1 centimeter max to kind of spread out where that cold spot happens, also where that hot spot happens, and get a more homogeneous distribution. So typically every 5 fractions, we're moving the fields on the order of about 5 millimeters. And essentially when we do that, what we're doing is just shifting where that match point is. So we're spreading out the hot and cold spots. Now, when we're doing CSI, whenever possible, we do prefer protons. And this is a retrospective study, first author Kahali et al. From the JCO 2020. And this retrospective study compared intelligence test scores between 79 pediatric patients that were treated with CSI for the same, for medulloblastoma on the same protocols. And the only difference in their treatment was the modality, so protons versus photons. And what they found is that the patients treated with photons actually had significant decline in their global IQ, working memory, as well as processing speed, whereas proton group exhibited stable scores in all of the domains except for processing speed. So we do have data that protons are superior to photons in terms of neurocognitive outcomes. It's also thought that protons, because of their Bragg peak, will result in less dose kind of anteriorly inside of the patient, so less dose to the bowel, thus decreasing risk of secondary malignancy and things like that. So protons really are preferred whenever possible, but understanding that not all patients will have access to a proton center, photons can be used as well. In the modern era, there's some data for using VMAT technique rather than this complicated matching field CSI technique. And with VMAT, you still have different fields that are created, but then they end up creating a dose gradient over a 5 to 10 centimeter period. So, the dose from the top field decreases over a distance of about 0 to 5 centimeters. And then there's the adjacent field has kind of an opposite gradient where the dose increases linearly from 0 to 5 centimeters. So that kind of creates opposing dose gradients between fields. So that there is still some, complex math that needs to happen even for VMAT, but that is another option for treating rather than the fields that I demonstrated. But big takeaways here should be CSI, how we think about these fields, what we need to do to match them appropriately, and then, we have data that protons are better for CSI. The last few thoughts that I'll leave you with are kind of the toxicity from CSI and how we counsel patients on what to expect. So there are acute and late toxicities from radiation. And in the short-term period, it's typically what you would expect. So dermatitis, fatigue, hair loss, headache, nausea, vomiting. Patients may have diarrhea, and they may also have cytopenias from CSI. It's a pretty toxic treatment. The late effects, however, are probably what parents are most concerned about when they hear about CSI. And a big, kind of late effect is neurocognitive dysfunction. And, most patients that are treated with CSI, and the risk kind of increases with younger age, but they will need some sort of, kind of help in the future for intellectual disabilities. And they do have decreased IQ from craniospinal irradiation. They almost always also get, hypopituitarism and endocrinopathy, so they can have growth hormone deficiencies, hypothyroidism, gonadal dysfunction. They can have decreased growth in truncal height because of the dose to their vertebral bodies. And, one thing that we think about when we're treating kids that are still growing is actually prescribing a homogeneous dose to vertebral bodies. We try to cover them with a minimum dose, usually around 18 gray, across the entire vertebral body, just to ensure that they get a uniform dose. So one thing that we can do is, if we're not sure if the growth plates have fused or not, we can get x-rays of the hands and knees to evaluate. And then if kids are still not skeletally mature, we definitely need to make sure that their vertebral bodies are covered with a minimum of 18 gray, so that whatever kind of stunted growth happens from the radiation is happening uniformly. And if we didn't do that, then they might have kind of a heterogeneous growth pattern in their vertebral bodies, which would be not ideal. So we try to prescribe a minimum dose to the vertebral bodies, usually around 18 gray, just to ensure uniform growth for children that are not skeletally mature. Other late side effects we think about: weakness and ataxia, risk of fractures, risk of stroke, cataracts, hearing loss, necrosis, secondary malignancy for sure. And we talked about how meningioma can often happen from exposure to craniospinal irradiation in the past. And, depression and anxiety can happen as well, kind of as downstream effects of everything that children go through from the CSI. So again, these are not at all insignificant. These are very kind of life-altering, very difficult for parents to hear, kind of the side effect profile from CSI. So it's very important to be familiar with these and kind of keep in mind, what to expect when we're counseling patients and families. So that wraps up our overview of craniospinal irradiation. Hopefully that was helpful to kind of understand some of the physics aspect and There are questions on the board exams related to the equations for, the angle of the collimator rotation or the couch kick and things like that. So hopefully this was helpful for that purpose. Again, I want to emphasize, I literally just kind of copy pasted this talk from the second half of my pediatric CNS overview. So it was largely geared towards pediatric patients that are getting CSI. I just thought it would be beneficial to kind of separate this talk and put it in the physics playlist as well, because this topic is very relevant to physics. So once again, hope this was helpful to you, and thank you so much for your time and attention.